So welcome everybody to our quarterly policy update webinar. Happy Friday. As Nicole was just saying, it's a beautiful Friday here in Sacramento. So we hope that wherever you are in California, that you're getting to enjoy that as well. Thank you all for being here today. Seeing a lot of familiar names and faces, which is great. We always love having you. And for those of you, if it's your first time joining us for an Access webinar, welcome to our Access program. So we're going to get started here. Our presenter today is our policy director, Maron. She will be presenting the information today, along with, we have a special guest, Gail Groner, who's joining us as well. She is the Director of Strategic Initiatives at CBHDA. So thank you, Gail, for being here with us today. And then facilitating the webinar is myself. I'm Jocelyn Farrell, the Program Coordinator for Access. And we have Nicole Chilton, our Program Manager. And Grace is here in spirit, our Education Coordinator. This webinar is scheduled for 1 hour, so it's a little bit shorter than our usual webinars. It's being recorded and it will be made public. This will be posted to YouTube in about a week or so. We're going to launch a demographic poll at the beginning of this presentation, and that's just to get some basic information, basic data for us about where you're from, things like that. And then because it is a shorter webinar today, only 1 hour, we won't have the same amount of time we usually do for our usual Q&A. So what we'd encourage you to do as you're listening to the information and thinking of questions and comments, we encourage you to email them to us at access@calvoices.org. Put that in the chat as well, so you can access that information. And then a few ground rules before we start. As always, we encourage you to practice self-care. If you need to step away for a minute, that's totally fine. Model the behaviors that you want to see in others. And then honor your fellow attendees. So if you're interacting with people in the chat, we want to always assume good intent with others, focus on the issues and the facts at hand, not necessarily on individuals. It's totally okay if there's disagreement, but we ask that you look for areas of alignment, and then when you do disagree, to disagree respectfully, and try to be as solution-oriented as possible. If there's any other ground rules that you guys would like to include, feel free to drop those in the chat. And with that, I'm going to launch the poll and let Maron get started.
Hello, everyone. Happy Friday. So we have an interesting agenda. So we're going to start with the summary of the key provision of the Budget Reconciliation Act of 2021, referred as HR 1. We had this conversation, and some of the information is going to be familiar to you, but we think it's good to have that refresher since we're going to discuss the DHCS implementation plan for HR 1, and also the potential role of PSS and outreach and engagement. Of course, we are very delighted to have Gail Groner, the Director of Strategic Initiative at CBHDA. She will discuss PSS as a critical workforce and outreach and retention effort related to HR 1. We're also going to provide updates on the gubernatorial candidates debates and next steps, and AB 96 updates. Gail will weigh in on all these issues. And finally, I will have the CBH-BSHA Community Partner Toolkit. So with that, let's start the discussion. So you know about the medical program, so I'm not going to read all this stuff, but medical is a joint federal and state program. Eligibility has been based on income and other categorical requirements, including disability status. In fiscal 2026 and 27, the state allocates 224.4 billion, 48.8 billion from the general fund for medical to cover 14.6 million members. So the HR 1, as you know, it was signed by President Trump on July 4th, 2025. According to the Congressional Budget Office, it reduces the federal Medicaid spending by up to 911 billion over 10 years. It also increases the budget deficit by 3.4 trillion over 10 years due to tax breaks to the wealthy and corporations, and also will cost 10.3 million to lose Medicaid coverage by 2034. So HR 1 has a provision. It's called the Medicaid work requirements. Work requirement were not a condition for Medicaid eligibility. States could implement that policy through a waiver. In fact, we had that discussion using Georgia as a case study. Under HR 1, it mandates Medicaid members aged 19 to 64 with an individual's annual income of 21,597 covered through the Affordable Care Act Medicaid expansion to either work 80 hours per month, complete community service, participate in a work program, enroll at least part-time in an educational program, or any combination. It also requires a 6-month eligibility redetermination for that same group. What happened to non-compliance? States send a non-compliance notice to Medicaid members, and they have 30 days to comply or to be disenrolled. So under HR 1, states must review and verify that Medicaid applicants have met work requirements for 1 to 3 months before enrollment. Additionally, state must ensure that current enrollees meet the work requirement for at least 1 month during each 6-month eligibility review. The Secretary of Health and Human Services is required to provide guidance by June 1st, 2025. There are exempted individuals, including those who have a substance use disorder and disabling mental disorder. We have an exhaustive list, which you will have next week as part of the PowerPoint presentation. It also requires state to impose up to $35 per service cost sharing on expansion adults at 100 to 138% federal poverty level, those who make 15,560 per year for a single adult. Although there's a family cap at 5% of income. As we discussed in the past, most Medicaid enrollees are working. The Kaiser Family Foundation, based on the information we received, almost 64% of this Medicaid enrollee are working part-time or full-time, and the rest who are not working is due to illness or disability, or they're attending school, or retired, or inability to find work. So it's really unnecessary and cumbersome for no practical purpose. Key dates under HR to remember: the restriction federal funding for certain qualified non-citizen be effective October 1st, 2026. The work requirements will be effective on January 1st, 2027. The 6-month eligibility redetermination will be effective January 1st, 2027. As we discussed in the past, there are excluded individuals, including medically frail. That list is available for you to review at your convenience. So HR 1 impacts the healthcare in California. So because of the work requirement provision, an estimated 3.4 million medical members may lose coverage, increasing the uninsured rate and provider cost. Because of 6-month eligibility redetermination, up to 400,000 adults may lose coverage. There's also a tremendous fiscal impact in California because of the work and community engagement requirement. An estimated reduction of 373 million, which is 102 million general fund in 2026 and 27, and 13.1 billion and 3.6 billion general fund by 2029 and 30. a reduction of federal matching fund from 90 to 50% for emergency services for AC adult expansion population with unsatisfactory immigration status will cost 558 million general fund in 2026 and 27 and 872 million general fund by 2029 and 30. As a result of the 6-month redetermination, it would result in a decreased caseload and a potential reduction of 463 million, 74 million general fund in 2026 and 27, and 3 billion and 474 million general fund by 2029 and 30. All this information will be included. You don't have to take notes. The reduced retroactive medical time frame from 3 to 1 month, it would cost 23 million, and then 10 million general fund in 2026 and 27, and 48 million, and that 20 million general fund ongoing. So the shift from satisfactory to unsatisfactory immigration status would affect about 200,000 people. Providing full scope medical to those with unsatisfactory immigration status is estimated to cost 782 million in 2026 and 27 and 1.1 billion in ongoing general fund cost. All that information, also the sources, is available to you. HR1 impact also social safety net programs. As we discussed in the past, an able-bodied adult without dependents was a person between the age of 18 and 54 who could work and did not have children under the age of 18 in their CalFresh household. Now that has changed, and the age expanded to also include age 55 and 64, and also age of dependent child lower to under 14 for exception. The impact is an estimated 303,000 individuals are at risk of losing eligibility, and that equals to a loss of up to 499.1 million federal funding yearly. The impact on CalFresh, particularly for non-citizen eligibility, because of the change as to who's qualified for those non-citizen, as a result, an estimated of 73,900 non-citizen will lose eligibility, and this amount to up to 133 million federal funding loss yearly. The administrative cost sharing is a big one. Before, the administrative cost evenly split, the federal 50, the state 50. Now that changed starting fiscal year 2027, the federal share will lower to 25 and the state share will increase to 75%. The estimated impact is 685.2 million additional cost to California, and that is 472.2 million general fund and 211 million county funds. Gil, I'm sure, does not like that. Impacts on California counties: increased workload due to extensive and frequent work requirements for CalFresh. Impact per the coalition of county representatives in the hundreds of millions of dollars. They said CalFresh funding will also then compete for resources currently supporting other social services, health, and behavioral health programs. So the federal administration cost sharing has increased from 15 to 22.5, resulting in an estimated 211 million impact on counties. So as we discussed in the past, there are key dates that we have to keep in mind, and that the Secretary of Health and Human Services is required to provide guidance by June 1st, 2026. Medicaid agency must conduct outreach between June 30 and August 31st, 2026 via mail, text, message, or other commonly available electronic means. As you can see, it's only 2 months. So the work requirement, as we discussed, is January 1st, 2027, and the renewal is January 1st, 2027. Course sharing for adults effective October 1st, 2028. Luckily, the Department of Healthcare Service has planned to implementing HR1. On January 29, 2026, DHCS published implementation plan for new federal eligibility enrollment change under HR1. Its intent is to inform medical members, providers, managed care plans, counties, community partners, and other stakeholders about expected change. DHCS, of course, expect the Secretary of Health and Human Services to release the interim rule by June 1st, 2026 to implement the provision of HR1. So DHCS anticipates concern. According to that report, significant manual administrative workload to support members in retaining coverage. They plan to maximize automated data verification whenever possible, though the work and community engagement requirement are expected to reduce its success rate. Counties must reach members who failed to auto-renewal for verification. DHCS expects significant disenrollment due to the extremely short implementation period. We looked at it, it's only 2 months. So they do have strategies for enrolling and maintaining medical coverage. So according to that report, the following are some of the strategies to maintain medical coverage. And one is automate coverage protection. They plan to use data sources to verify compliance or exemption from work requirements, minimize paperwork, and ensure coverage stability. They wanted to establish clear and culturally relevant communication and streamline renewal process. They also wanted to provide comprehensive training for support staff, train county personnel, providers, and HR1, providing clear guidance and resources to support members effectively, and proactive and transparent member communication, that is to disseminate timely information about HR1 change across multiple channels to ensure members are prepared to meet new requirements. They also have some exemptions, optional exemption they're looking at, including emergency declaration in the event of an emergency or disaster declared by the president, hardship exemption for those who live in jurisdiction with unemployment rate at or above 8%, 9 or 1.5 times the national rate, individuals receiving inpatient care, or if a person or their dependent travels outside of the community for extended medical treatment during the work requirement month. So there's funding to comply with the HR1 work and community engagement requirement. So the 2025-26 fund relating to HR1, there's a 15 million, and that is 7.5 million general fund for state and county communication campaign and implementation efforts. You can take a look at the other, but this is important for us. I'll explain in the next slide. There's also the proposed governor budget and the 2026-27 includes 4 million, 2 million in the federal funds, and 2 million in the reimbursement from the foundations for navigators to assist with medical eligibility, enrollment, and retention. So are there advocacy opportunities? We think we do. Nearly 15 million Californians, 38% of the state population, are enrolled in medical. Proposed federal funding cuts and new eligibility requirements could threaten coverage for millions and strain the state's health system. We think um, peer support services can effectively educate the millions of medical enrollees about the new work requirement and reporting procedures under HR 1. So Call Voices has a proposal, and we are working closely with CBHD on a budget discussion. We have asked Senator Smallwood Covia, I don't know how to pronounce her name, Cuevas, and Senator Weber Pearson to sponsor a budget request to include certified peers alongside navigators to assist with medical eligibility, enrollment, and retention, and leverage the effort for outreach and engagement with clients affected by HR 1. Because both sit on the Senate Budget and Fiscal Review, they were unable to sponsor the proposal. They expressed strong support. We also submitted our request to Senator Caroline Menjivar, chair of the Senate Budget and Fiscal Review Subcommittee 3, to include our proposal on the March 5th agenda or future hearings. We plan to reach other members. So our ask is to make PSS eligible for the following funding as to be able to do the navigation under HR 1. And that is in the current year funding, the $50 million, also in the 2026 budget proposal, that $4 million. Call Voices also asked Call HHS through the peer leadership work group to strategize on how to include peer support specialists in the critical outreach and retention effort for medical members related to HR 1. We'll address this issue with Stephanie Welch, the Deputy Secretary of Behavioral Health at California Health and Human Services Agency in mid-March as part of the peer leadership workshop. So with that, Gail Groner, Director of Strategic Initiative, CBHD, is here. Gail is responsible for helping lead budget and advocacy efforts and provide strategic guidance to advance CBHD's mission. Before joining CBHD, she spent over 2 decades working in and around the California State Capitol. Most recently, she was a special assistant to the Speaker of California State Assembly, serving as a member of the leadership policy team for the tenure of 8 speakers. Prior to the Assembly, Gail worked with the Los Angeles County Department of Public Social Services, Bachelor of Arts. She holds a Bachelor of Arts dual degree, English and French from Stanford University. Also, Juris Doctor, a member of the California State Bar from UC Davis School of Law. I am extremely happy and privileged to invite Gail here, and she will discuss CBHD's perspective on the peers and their role related to HR 1.
Thank you, Marone, and hello, everyone. I'm so pleased to be here to connect with you. I just want to say that I know there is so much going on right now in the world around us, federal level, state level. There are a number of challenges, and part of my previous experience included helping to work on implementation of federal welfare reform back in the day, which also included very significant troubling changes in federal law. And it led to advocacy over a few years to help establish additional state program funded support to help support communities affected. So I liken that to this era, although admittedly the magnitude of the impact of this is larger. But we all remain very dedicated to advocating as much as we can to do what we can this year to alleviate concerns that people have and to keep working at it in the coming years. There may be changes in the federal landscape, and that is something that we look forward to and hold out hope that can help affect what's happening now. Maron, I so appreciate your summary, and there is a lot of moving parts and a lot of interaction in the federal enactment. And so I think part of the challenge is you noted that the federal government is due to issue additional guidance in June. So we're very curious to see what that entails. And I know the state is very curious to see what they touch upon, because the current provisions of HR 1, as you indicated, includes ways to help support those with behavioral health need, with mental health and substance use need, regarding work requirements. There are exemptions permitted, included in the federal law. And, luckily, the State Department of Healthcare Services is looking for ways to capture that via the automated system that contains information that could help the data system just simply check the box that someone is exempt. So that is a notable effort that they are making, and a really exciting approach that they're working on. I would just also note part of the background that you noted, Maron, are the cuts to federal SNAP or CalFresh in California, and the fact that it's the County Welfare Department, our colleagues at the County Welfare Department, who conduct eligibility. And I wanted to flag that, as your presentation notes, one provision in last year's state budget includes $20 million to help County Welfare Department eligibility workers prepare for this implementation. So I just want to flag, there was an informational hearing yesterday. That funding has not yet gone out, and that remains a discussion among the state legislators and the counties and the Department of Finance. So that conversation continues. So in the meantime, the role that peers play in connecting with community is essential and so important that we have a trusted voice for community that can help communicate with people who might be affected. We know from this past year, from the first term of this president, that with so much attack on community and fear of government, that people are reluctant to communicate with government. And it's so complicated. It's challenging to understand the levels of government. And so we have seen that kind of hesitation to communicate. And so I think it's even more important than ever that we are including and working with our colleagues who are peers and doing that outreach and engagement to help create a trusted environment for communication. It's an extremely important part of rolling things out related to HR 1 and in general. We also have advocated in the past to include funding for outreach to our communities who are unhoused. And we have proposed that in the past and would love to make progress on that point, because it's not eligible. In the past, it's not eligible for Medi-Cal funding. So that is something that we think would also be very meaningful for communities to help connect with peers and people with lived experience who could help do that communication in a trusted fashion with people who are unhoused to help connect to what they need, what they're ready for. So as we approach this coming year, as Maron stated, we're very eager to try and include certified peers in efforts to outreach to people in need, to have that trusted voice. There are various ways to approach that advocacy. We're early in the year. There are significant number of hearings coming up and informational hearings, opportunities to help get that advocacy out there. And so we think that's very important in terms of helping support our clients and community as we all navigate this implementation period of the federal bill. So I'll just pause there.
Thank you. We're grateful for your tremendous advocacy, for your help, and for your really care for the peer support workforce. We are grateful. Thank you, Gail. So now we'll move to the post. We had a discussion about the gubernatorial candidate debate. Now we're going to discuss about the post. And so, as you all know, Cal Voices co-hosted a gubernatorial candidate debate on February 3rd, 2026 in San Francisco at the Ruth William Memorial Bayview Opera House. And it was broadcast live in partnership with KTUV Fox 2 Bay Area, KTTV Fox 11 Los Angeles, and Fox local streaming statewide. The debate brought together leading gubernatorial candidate for one of the earliest and most substantive forum of the 2026 election cycle. The debate was successful thanks to our partners, including the Black Alliance. One question we asked, we presented a question to all the gubernatorial candidate forums, and regarding the behavioral health workforce, we asked them, what is your commitment to exploring policy options to make peer support service a covered medical benefit? So they provided this information to us in writing. So I'm not going to read all their responses, but I'm just going to highlight what they said about related to peers. So Antonio Villargasso said, protect medical reimbursement for peer support and community-based services. Betty Yee expressed her commitment to making peer support service a covered medical benefit. Congressman Eric Sowell said, I'm going to read only a portion of that. As governor, I commit to exploring and advancing policy options to make peer support service a clearly defined, consistently reimbursed medical benefit that includes standardized coverage requirement across managed care plans, ensuring fair reimbursement rate, and expanding training and certification pathway. Matt Mahan also said, fully integrate peer support specialists. California already has over 8,000 certified medical peer support specialists, but too many are underutilized. He said, I will require medical managed care plans to meaningfully contract with peers, embed them in crisis response team and housing programs, and track outcomes such as hospitalization reductions and treatment engagement. He said, yes, I am committed to exploring and implementing policy options to make peer support services a covered medical benefit statewide with quality standards, cost controls, and performance reporting so taxpayers know the investment is delivering results. Tom Steyer also said, I recognize peer support services as a transformative resource for achieving health equity, building on my work chairing the task force that established California Racial Equity Commission. I will strengthen peer support and look at how we can integrate it further into the overall state health care policy. Tony Thurmond also said, expand community-based care by investing in school-based mental health, community clinics, mobile crisis team, so people can get help before problem become emergencies. And Xavier Becerra also said, peers are essential, especially for Black Californians, facing both a provider shortage and justified mistrust. I will pursue medical coverage for peer support service as a priority. Steve Hilton didn't really address it, but he's the Republican candidate. He said we need to make sure we lower healthcare costs and wait times, especially for working class Californians, before we consider expanding into other programs. So what is the next strategy? Now we had that very successful debate. What we're going to do is educate voters, provide comprehensive data-driven analysis of candidate commitment to enable informed voting decision across the June 3rd primary and November general election, build accountability infrastructure, create tracking a mechanism to hold elected officials to their promises beyond election day, and strengthen coalition capacity, deepen partnership across aligned civic engagement and community empowerment organization through collaborative research and shared advocacy. All the resources, if you wanted to watch it on demand viewing, you can go to the link to access the gubernatorial candidate questionnaire, including the responses about PSS. The link is available to you to offer a community feedback survey. Please, you can do that. Since Gail attended the debates, I would love to hear your points of view, Gail.
I so appreciate the chance to participate. We volunteered. It was just a fantastic experience to see how the candidates prepare for the event, how they interacted with the moderators and the interviewers from the San Francisco station, the LA station it was a live event. It was really fascinating. They had 1 minute to reply and covered a number of areas. And I do appreciate the answers that emphasized how important services are for people who are experiencing challenges. So it was really just a fantastic way to get a sense of the candidates and see how they respond in that kind of setting and under pressure.
So, Gail, since you are a long-time political observer and a policy wonk, can you tell us why having this sort of debate is important to advance the issue affecting the peer community?
Well, I think it accomplished a few different things in that it is an opportunity for candidates to articulate how they would tackle the very challenging issues across California. And they did refer to services a number of times, which I think is important to flag that theme. I think also there are so many candidates. This is an unusual year. Many candidates, and there is still this, we're still in this space of getting to know candidates better and understand where they're coming from. So I think that, being the governor of California is a powerful position. The governors have a very significant profile and platform to put issues and priorities out there. I know a number of candidates expressed that they would be interested in participating in meetings to help further understand community feedback. So, one person will get elected and they will have some frame of reference likely have some frame of reference for these issues when they take office next year. They will be appointing high-level officials. They will be crafting a proposed state budget next year. There are many different ways in which the governors play a very significant role in supporting and constructing the programs that we all care about.
Thank you. Now we're just going to have briefly provide you with an update on AB 96. Again, it's co-sponsored by CBHDA. It removed the high school requirement for certified medical peer support specialists. We all were participating in this, and so I'm not going to go in great detail. So currently the status, it's in the Senate Rules Committee. It passed the Assembly with 0 no votes. Yay. It enjoys the support of over 20 organizations and counties, including the counties of Sacramento and Alameda. We have attached a coalition letter, which displays the many organizations that support AB 96. Since we have Gail, she will tell us exactly from the perspective of CBHDA and why they decided to co-sponsor this important legislation.
Thank you, Marone. We are very mindful that we need more opportunities for peers to be involved in program and be able to work. And we heard from a number of our folks that the high school graduation degree can be really an unfair barrier to participation in being able to be certified as a peer. So I think again the voice of lived experience is really critical in connecting with community. And so we were happy to help co-sponsor and support this important change to make the pathway more accessible.
Thank you, Gail. This concludes the policy updates section of this presentation. I am extremely grateful for joining us, Gail, and thank you for your insight, expertise, and guidance, and thank you for your time. And I'll pass it to Jocelyn.
Thank you, Maron and Gail. Super insightful as always. We just want to end by highlighting the Community Partner Toolkit. This was recently published by the Commission for Behavioral Health, CBH. And this is a toolkit that's meant for all of us to be able to be more actively engaged in the community planning process. That's often something we hear from people is we don't know where to start, how to start, what steps to take, even what language it is that we're speaking when we talk about all of this. And so this toolkit is designed to help with that. So in this toolkit, which I will post in the chat, you'll find there's a glossary of all the terms. There's was like a timeline for when to get involved, how to get involved, explanations of the funding streams, and the different buckets of funding in the BHSA. If you want to get involved with public comment, there's even outlines for how to do that, tips for how to give an effective public comment. So it's a really helpful resource. We encourage you to use it yourselves, to share it with your clients or your partners or anybody else in your life that is interested in advocating as well. Thank you.
So with that, we're going to conclude the webinar. Thank you so much for coming. We appreciate your time. And if you have any questions, please feel free to share them with us. Thank you, Gail, for joining us again. We are very grateful for your time and expertise.
Thank you, Gail. Thank you, Maron. There was a question in the chat. I know that we said any questions you can send to access to our email address, access@calvoices.org. And there was a specific question if there's Q&A time with Gail. So I'm wondering if we can accept those questions also on behalf of Gail and send those over, or does that work for you?
Absolutely.
Okay.
We can arrange that. Thank you for accepting that, Gail. We appreciate you.
All right. Thank you, everyone, for being here. Thank you again, Maron. Thank you, Gail.
Thank you all. Great seeing everyone.